good afternoon, everyone. Hi, welcome back, everybody, after the lunch break. Are you hearing me okay here? Yeah, great. So hopefully everybody is now suitably refreshed after the lunch. I'm Ashley Duffy. I'm a consultant psychiatrist for older adults in NHS Tayside and lead for the mental health network for Tayside and Fife. I'm delighted to announce 3 speakers for this segment of the programme. The theme of this segment is novel therapies and approaches for mental health treatment. And especially following the challenges of COVID, I think it feels really positive to hear about progress and developments. Feels like a bit of good news, perhaps. Our first speaker is Professor Paul Hutton. He is Professor of Mental Health at Edinburgh Napier University, an Associate Director of the Edinburgh Research and Innovation Centre for Complex and Acute Mental Health Problems, otherwise known as ERICA. His research interests focus on understanding and reducing psychotic symptoms and understanding and improving impaired decision-making capacity in the context of psychosis. Professor Hutton helped to develop the 2018 NICE guideline on supporting decision-making for people who may lack mental capacity. And he was also part of the Capacity and Supported Decision-Making Advisory Group, which informed the recent Scottish Mental Health Law Review this year. So welcome, Professor Hutton.
Right, which microphone shall I use? This one? Okay, can everybody hear me okay? Yeah, I don't know if there's any way to confirm online, but sure, they'll tell us. Yeah, exactly. So this is brilliant because Richard having gone first this morning really makes my job a lot easier in terms of explaining umbrella trials and the potential benefits. So I'm going to skip over some of the benefits of that. But so I'm going to talk today about this trial we're doing, the DECIDE trial, and it is an umbrella trial. We think it's the first umbrella trial that's being performed in mental health. And Amanda Woodrow is going to talk about the second later this afternoon. So there's a lot of innovation happening in Scotland around trial design. And if I can just say, I was just chatting to Richard briefly there, and the origin of the idea of using an umbrella trial actually came up at somebody's leaving do down in Manchester. Is that right? I was sat next to Richard just by chance, and we're chatting away, and I was really struck by something Richard said, which is that mental health research is 10 to 15 years behind cancer and heart disease and so on. And that really struck me because it just suggested there's lots we can probably do to kind of bring things a bit more up to speed. And we corresponded since then, and we came up with the umbrella trial as one methodology to use to really speed things up in this important area. The whole thing around capacity goes back a lot further, goes back to my clinical training in Manchester and working with people with dementia and so on, and thinking about the way the English conceptualize capacity and work with capacity. That had a big influence on me and the importance of it. And I was also really interested in psychosis. So the two things came together, or 3 things. So why is capacity important? Well, I'll talk about what capacity is and how it's defined later. But we know that formal compulsion and informal coercion is common in mental health services. It reflects at least 3 things, I think. That clinicians have ethical legal responsibilities to protect the person and others around them. That mental illness, severe mental illness, is by definition very complex and very severe, and it's very hard, it's very difficult to help people effectively. But also one of the reasons that's really hard is because the resources are so low. So one reason we're 10 to 15 years behind cancer and heart disease is because we just get far fewer resources, and I think everybody here will agree with that. Capacity is probably important because one reason being that prescribers see impaired capacity as a major barrier to using shared decision-making with schizophrenia. We all know that shared treatment decision-making is required really by most professional organisations and NICE and so on. The concept of capacity is tied to autonomy, dignity, agency and empowerment, and these concepts are particularly important to people with diagnosis of schizophrenia or severe mental illness. And most psychiatrists, philosophers and ethicists would also regard autonomy and the respect for it as having what referred to as an intrinsic value. And by that, I mean its value doesn't depend on the effect it has on some other outcome. It just is important. It's a bit like saying, why do we want to help that person with their pain? Well, it doesn't make a lot of sense to say, well, because of the effect on some other outcome. We just don't like to see people in pain and suffering. It has intrinsic value to reduce suffering and mortality and so on. And I think that's the same with autonomy. That being said, it also has value insofar as it, helping people regain autonomy does reduce suffering as well. So this isn't a new idea that autonomy is important. It goes back centuries. But this is from the 5th edition of Beauchamp and Childress. I think there's several more editions since then. But this is a key statement. And the bit that's really important is this bit. I'll come back to it. To respect an autonomous agent is at a minimum to acknowledge that person's right to hold views, to make choices and take actions based on personal values and beliefs. Such respect requires respectful action, not merely a respectful attitude. And it's more than non-interference in other personal affairs. It includes, at least in some contexts, obligations to build up or maintain others' capacities for autonomous choice, while helping to allay fears and other conditions that destroy or disrupt it. So that means respecting capacity and autonomy isn't just about leaving people alone. It's about supporting them to have capacity, regain capacity, keep capacity, or keep their autonomy. It's an act. You can take an active stance to it. A passive stance to it, just leaving people alone, not interfering in their lives, is probably what happens when you combine not providing enough care with respecting autonomy. And respecting autonomy has been misused to kind of provide cover for those things, I think. So this is one way of thinking about it. So at the bottom here, the sort of 4 components that tend to, across different legislatures across the world, seem to kind of coalesce in these 4 kind of areas. Understanding, communicating, weighing, and remembering information relevant to a particular decision. And it's related to autonomy and empowerment. It isn't, I guess, the way to think about this in relation to treatment decisions. It's not sufficient for autonomy and empowerment, but it's probably necessary in many contexts, if that makes sense. So I want to just briefly talk about some critiques of the concept. And these are new slides because it's become more and more important to talk about this as time has gone on. And one reason for that is this partly welcome, partly problematic general comment from the United Nations Convention on Rights of Persons with Disability, a committee charged with interpreting that. And this is a really key document. It's having a huge amount of influence throughout the world on law and practice. And it's very controversial, and it remains so. And it's had a huge influence on the Scottish Mental Health Law Review that was published just a couple of months ago, final report. And some of the critiques of the concept of capacity come from the United Nations, the CRPD committee. And they, in particular, they say it presumes that we can accurately assess the inner workings of the human mind. And yes, I suppose is the answer to that, it does. Accurately, more or less so, but it does assume that we can, at least sometimes, assess things like memory, reasoning ability, and so on and so forth. But if we can't completely, but we can to some extent. One of the critiques of the concept is that different people will judge it differently. So that's almost certainly valid for a proportion of cases, but not the majority, I would say. We know that most of us have the capacity to make our own decisions about treatment and other matters. We also know that lots of people who are severely unwell, people who are, the classic example, somebody's in a coma, somebody who is unconscious, somebody who has had very, very severe brain injury and so on. Most people would agree they're not able to make their own treatment decisions. And to assume that they can, because of some utterance that they make or some gesture that they make, would be pretty dodgy, right? But also, it's important to remember that reliable classification is a universal challenge in healthcare, and it's not just specific to capacity, particularly with complex cases. Another criticism by the UN is that the concept is subjective. It involves the values and idiosyncratic beliefs of the person doing the assessment. Yes, it does. But again, that's something that is applicable to almost every concept they work with in healthcare, even ones you think don't do. Cancer is bad. It involves a value judgment around mortality, tumours, and so on. It's one that we all tend to agree with. It's an uncontroversial value judgment, but it involves it. In capacity, we have controversial value judgments. That's the difference. But it involves determinations of facts, performance in a test, of verbal memory, but also values that are contingent on social and political context. Some more critiques that it's contingent on the social and political context, and this is really important. And I should say that these critiques of the concept of capacity find themselves echoed in the Scottish Mental Health Law Review and projected forward into our law in Scotland, and they're having a big influence. And that's why it's important to address it. I will talk about my trial as well. Take the opportunity to bend your ear about this. One of the critiques is it's a social construct. But lots of things are. Human rights are a social construct. They're not God-given. They're not grown on the planet like trees, or they're not rocks or whatever like that. I would agree that it is discriminatory. It has been discriminatorily applied to people with disabilities, but that's not the concept itself. That's a use of the concept. And I've talked about how mental capacity is not the same thing as impairment. This is a position of the Scottish Mental Health Law Review, and they believe there's considerable force in the committee's arguments, the ones I've just outlined, but there are also some practical difficulties. I would say that there's not just practical difficulties, there's really conceptual difficulties in their wholesale rejection of the concept of capacity. But this is their position. However, we strongly agree that a substantial change in approach is needed to strengthen respect for the autonomy of people with mental and intellectual disabilities. They also note here, though, that the critiques of the concept of capacity do apply to the things that are being offered as a replacement. And what they've come up with instead of capacity, and this is important to refer to because it directly affects the importance of our trial results, they've come up with something called the autonomous decision-making test. And they suggest that that is going to replace the existing capacity and sigma tests as providing a more rights-based approach. However, this is how they're defining the autonomous decision-making ability test. Does any of that look familiar? So it looks a little bit like that, doesn't it? So it's a stigmatized term. Now, capacity has become stigmatized in some respects because of the UN committee. But I don't necessarily think changing the name is a solution to getting rid of the stigma. It does work sometimes. But I've been in mental health research for long enough now to get a little bit weary of the continual attempts to change names of things to make them more acceptable. One thing that is different about it is it's going to apply to all of us, not just people with mental or intellectual disabilities, which is to many psychiatrists quite controversial. Want to move on to supported decision making. What is it? Well, I see it as part of, but distinct from, a broader family of approaches aimed at promoting autonomy and empowerment. And that broader family is advocacy, advanced statements, choices or directives, shared decision making. I think these things are around promoting autonomy. I don't think they're supported decision making. And that puts me at odds with the Scottish Mental Health Law Review. Because I think, well, I'll come to that. So supported decision-making can be provided to those whose decision-making is intact. I'm focused here on those whose decision-making ability has been questioned or is in doubt. This is broadly the conceptualization of supported decision-making in the Code of Practice for the Mental Capacity Act and in the NICE guideline that you refer to. And I should say that the DECIDE trial that we're doing is focused on internal threats to capacity. But we all, and I agree that there are very much there are a lot of external threats to capacity too. But just because we're not focusing on them in this trial doesn't mean we don't think they're important. This is how the Scottish Mental Health Law Review defines supported decision-making, really. And they describe it as advanced statements, powers of attorney, decision-making supporters, which have been nominated by the person, not necessarily a clinician, and independent advocacy, special support. They don't really talk about the role of clinicians in this work, which I think is a really, really, really big problem, really, really big omission in the Scottish Mental Health Law Review. So what types of support for decision-making capacity are effective, safe and acceptable? Well, you mentioned the NICE guideline. This was 4 years ago this was published. Nothing much has changed. We don't have any evidence on what's particularly, when we talk about evidence, we're talking about evidence with a capital E, as it were, from randomized controlled trials. There are lots of observational studies of associations between treatments and capacity, but there isn't any higher quality evidence, as it were. So one of the recommendations we made in that NICE guideline was that we need to get some evidence. So how are we doing that? How am I doing for time? 8 minutes. Okay. So we've done a bunch of stuff. I'll go through this really quickly. We back in 2014, we held an event where we engaged stakeholders. We've done qualitative studies of this meta-analysis of the limitations of shared treatment decision-making, meta-analysis of the effects of what's associated with treatment decision-making capacity, and also on decision-making generally, not just decision-making for treatment. We've done a study of the jumping to conclusions bias in psychosis. I was just chatting about this earlier, and this is a tendency to make decisions quite quickly based on limited evidence. And the available evidence suggests about 20 to 30% of us, or the general public, would have this particular bias. But that rises to about 50 to 60% in people diagnosed with schizophrenia spectrum disorders. So it's not sufficient or necessary for psychosis, but it's highly correlated. So one of the first things we did is we did a trial of trying to reduce that bias in people with psychosis. This was an open trial. The assessor knew who was allocated to what condition, but it wasn't. It was an active control group. We randomized people to information about the jump to conclusions bias and helping them reduce it, or information about how the brain works generally, like a sort of neurological seminar type thing. And we found there was certainly in this very small trial, there was some evidence of some benefit, but it was very, very small. We also published this in Lancet Psychiatry a couple of years ago, which looks at the role of self-esteem in paranoia. And this will become more relevant when I talk about the interventions that we chose in this DECIDE trial. We found here that self-esteem is highly correlated, so low self-esteem is highly correlated with paranoia. So it's, generally speaking, the more lower your self-esteem, the more paranoid you're likely to be. And I really think it's important to remember this when we talk about some of the results. We did this paper with an advocate of this theory, Richard Bentel, and a critic of this theory, Daniel Freeman, who Richard knows well. So Daniel has given Richard an awful hard time about this theory over the years. So what we decided to do was bring them both involved, get them both involved, so that we could agree the results. And if you read the discussion section, it's very long. Essentially, it's a long argument between them and around what the results mean. So the DECIDE trial in 4 minutes. So this is us. It's lots of people involved, about 30, and this is in alphabetical order, most of it. Amanda, who you'll hear from, is trial manager. We've got Richard, Nadine, various other people involved in this. And thank you to everybody. Emma Eliasson is somewhere here. Where is she? There she is. She's worked for the network has been incredibly important. I just want to say that in the success of this trial through the pandemic, in particular, Dr. Emma Eliasson. So thank you, Amanda. It's the first single blind trial and the first multi-site trial of psychological intervention to support treatment decision-making capacity in psychosis, first umbrella trial. And our objectives really, because it's the first, is to determine feasibility, acceptability, and also gather some initial data on safety. And that will, if we succeed on those parameters, increase the probability of funding for a larger version. So what's an umbrella trial? I'm going to skip this. If anybody wasn't here this morning, anybody want a recap? Here's a good paper on it. And this is the top right diagram is essentially the umbrella trial diagram. And this is our umbrella trial. And the thing about an umbrella trial is it's an infrastructure for conducting multiple trials at the same time. So you need one ethics form, one participant information sheet, one consent form, one set of staff, as it were. And so so rather than doing each one after the other, which would be 10 years from now, right? By the time you finish that, you're just doing them all at the same time. The other unique thing about this particular trial is, again, it's highly influenced by Daniel Freeman's work, Richard and Daniel Freeman's work on intervention as causal trials, which is this idea of a specifically changing one isolated psychological mechanism, which we hypothesize is linked causally linked to treatment decision-making capacity. So what we sought to do for this in the self-stigma intervention was change self-stigma and self-stigma alone, as far as that's possible. In the JT Jumping to Conclusions trial, we sought to change that bias and that bias alone. And in the self-esteem trial, we tried to change self-esteem and that alone. The control condition in each trial was further assessment of the factors that help or hinder treatment decision-making capacity. So they met with a therapist for the same amount of time. The therapist was just as nice to them and just as warm to them, just as empathic, but just didn't try to change anything. So we're trying to control for those variables, which is a bit unusual in psychological therapy trials, which tend to aim to beat treatment as usual, which, as we know now, ain't so hard, right? We had 3 separate control groups because we reasoned that the participants who end up in self-stigma or the JTC trials or the self-esteem trials might be different in some important prognostic ways. So we had to have a separate trial, separate control condition for each trial. So it was pre-registered on the 16th of March. It was pre-registered on the 16th of March. 10 days later, we went into national lockdown. And so things were very delayed. And we restarted. Our first randomization eventually took place on the 28th of January. I'm not sure if anybody remembers, but we couldn't do research for a long period of time because the NHS said you can't do research that's not COVID related. Then after that, the psychiatric wards all shut in Edinburgh, in Lothian. That's right, for a long period. Yeah. And then my university said, no, you can't do research. You can't speak to people directly. That goes against our policy, so we had to appeal against that. So it was all against us, really. These are primary outcomes anyway, which is really recruitment performance. So basically, this is a long statement, but we just wanted to recruit 60 people, 20 to each trial, okay? Our second primary outcome was keeping those 60 people. Well, we want to randomize 60 people. We want to keep these people in the trial towards the end, or at least 75% of them. And the reason for that is there's a study showing that I'm on 20 minutes and 15 seconds, I think, so I'm okay. So the reason for that is that I won't go into the reason for that because I don't have time. These are secondary outcomes, number of blind breaks and data completion rates and all these different measures, which are fairly standard in psychosis research, depression, anxiety, quality of life, recovery, PANS, service use, so on. Secondary outcomes of what were related to safety. We had quite a sort of developed safety protocol: death by suicide, participants attempting suicide, people experiencing suicidal crisis, reporting non-severe adverse events as well. Because I think psychological therapy trials have been pretty rubbish to date in thinking about safety and adverse events. And historically, there's a lot of evidence that's the case. There's an assumption that they're brilliantly effective, but very safe. And we also wanted to look at the clinical validity of the MACAP. I won't talk about this in detail because of time. And as usual, we have the people's experience of the trial, qualitative interviews, and so on to find out how they experienced it. So people had to have psychosis, they had to have impaired capacity, they had to be adults, they had to not have a comorbid organic cause of the psychosis, an organic cause of the psychotic symptoms, and people with moderate to severe learning disability or people who couldn't speak English sufficiently could not take part. We required people to be in touch with services. People had to not present with an unmanageable level of risk of harm to our research or clinical staff. And we included people who lacked capacity to consent to research, and we allowed self-referral. And we had some adverts in the paper and on a bus stop in Princes Street and various other bus stops throughout Edinburgh, which had absolutely no effect on our ability to recruit people, but cost an awful lot of money. So the interventions, I won't go into it, but they involved pretty standard kind of cognitive behavioural thing, very, very prescribed interventions, very structured. And that's a more detailed table, which I don't have time to talk about. And we had 2 points of randomization, one to a trial for people who are eligible for multiple trials, and one within that trial to treatment or control. And this is our complex protocol for doing that. We had to change that when we were struggling to recruit. And essentially, what happened was that we ended up remember I said talk about the self-esteem stuff. Remember the self-esteem stuff. We found that actually relatively few people in this particular group had low self-esteem, which was a bit of a surprise to us, given all the evidence to date and so on. But it sort of makes sense if you listen to Richard Bentl's stuff around self-esteem being protective. It doesn't make sense if you think self-esteem is just low in psychosis. We had some people in our trial score the maximum score possible on the self-esteem measure. So the problem is we didn't have very many people with low self-esteem. So we had to change things a bit. We had to amend things to preferentially allocate people to the self-esteem trial if they presented with it. And we had to do other things, lots of other things as well, but I'm running out of time, I do apologise. So we had 57 individuals were randomised 60 times. So we had made an amendment to allow people to take part in more than one trial. So 57 people, we aimed for 60, we randomised 60. And the 60th randomisation took place recently. I'm going to skip this quickly and say that we formally assessed for eligibility 92 people, and off those 62 part, and those are the reasons why people didn't want to take part. We ended up with more people in the self-stigma trial and the JTC trials and the self-esteem trial. The self-esteem trial, we only ended up with 12. The people who would have ended up in that, we allowed them to go into the self-esteem or JTC. Another advantage of doing this type of trial is that you can do that. You can say, well, you can use your resources more efficiently. Missing data so far is acceptable, but we've done 50 out of 60 assessments at end of treatment, and we have only 16% missing data. We'd have to be really unlucky now to not hit that target, but there's every chance we might be. And I don't know how to think about this low prevalence of low explicit self-esteem, but only 32% of those randomised had it. That compares to 10 to 15% in the adult population, and about 80%, 60%. The study done in Glasgow a couple of years ago by Andrew Cumberley and others, 60% of people have low self-esteem. So the question really is, are we thinking about it the right way? And I think probably we found that, what probably hypothesize is that people do actually have good self-esteem because they don't believe that they're unwell. And so the big risk is if you start to persuade them that they are unwell, that you lower their self-esteem and cause depression and so on. So that's important, right, from a safety perspective. And that's the study there. And I will stop talking now because I've really run over ridiculously. Sorry.